All right, let's switch gears one more time. Let's switch to you know, if EGFR was described in 2004, let's fast forward to 2007, ALK.
Okay.
Recently, in the past 2 months or so, we had the approval of brigatinib, the third second generation. I don't know if they're second generation or first generation ALK inhibitors.
Well, there's no, I mean, you can call them any generation you like, which becomes a little bit more marketing than science.
Yeah.
So if you and I want to develop a drug, we'll call it a fifth generation.
Okay, good. Yeah. So walk us through that drug, the FDA approval, and your thoughts about it.
So on the one hand, you could say, well, do we need another next generation? I say next generation because it just avoids that.
Okay.
Another next generation ALK inhibitor. We already have ceritinib licensed post-crizotinib, alectinib licensed post-crizotinib, and now we have brigatinib. And if you look at their response rate, they're all about exactly the same. They're about 50%, 55% post-crizotinib. But as we've seen the data mature, we can see that there are differences. And in terms of efficacy, the two big differences are the duration of that control. So if you look at the median progression-free survival, for ceritinib, it's about 6 months. For alectinib, it's about 7 or 8 months. And for brigatinib, we now have 2 studies at their dose where the up-to-date data is running nearly 16 months. And that's kind of clear water from alectinib. The other area, which is, you kind of get the feeling there's differences, but it's hard to really compare, is their CNS efficacy.
Yeah, I was going to ask you that.
And the reason that's hard is because we've kind of backed into the idea that, hey, we need to capture robust data in the CNS. So there's a lot of retrospective stuff. Right. Again, they all have responses in the CNS, but when you start to pull apart, you know, the duration of those responses, bear in mind not everybody got MRIs at the same frequency or called a target lesion the same way. But if we use brigatinib, because that's the most recent data, that has a median duration of response of 18 months in the CNS. I mean, it's pretty impressive.
Yeah. Mark, your thoughts about the increasing number of ALK inhibitors?
I think it's a good thing, and just as Ross said, these drugs are not exactly the same. They're pharmacologically different. They have a different spectrum of side effects. They clearly have different efficacy, CNS and systemically, than crizotinib. And there have been randomized trials that have shown that. So it's good to have more drugs, though, I think, for individual patients. And then if you get into what's the best drug for the different kinds of resistance mutation, having more drugs gives us more options.
So getting to your point, last year at ASCO, we saw the J-ALEX trial. This year at ASCO, we'll see the ALEX trial. And is that going to change our standard of care?
I think it will. I mean, so I really think this is the beginning of a sea change. And there are analogies with flora, which is, you know, what happens if you take a drug that has potentially broader spectrum of coverage in 2 ways? Maybe it covers a different part of your body, the brain. Maybe it also covers some of the mechanisms of resistance too. And so that's alectinib versus crizotinib. In J-ALEX, we've seen in the most up-to-date data that the median progression-free survival is more than double when you go on alectinib. It's something like 11 months on crizotinib. It's about 25 months in the latest data with alectinib. And I think ALEX is going to look very similar to J-ALEX. So it changes the standard of care.
So does crizotinib have a role?
Crizotinib will have a little plaque in the museum.
Okay. Used to have a role.
It has a role as a MET inhibitor.
Right. I meant an
and a ROS1 inhibitor.
And it's damn good for ROS1.
Yeah.
It's going to be very hard to beat for ROS1.
Yeah.
So what do we know about, so if alectinib is going to move up to be our new standard, what do we know about the other 2 agents, ceritinib, brigatinib, after alectinib?
That is it. You know, you have these moving pieces of the puzzle, and we are in the somewhat data-free zone. So we have essentially very little data other than anecdotal of, you know, ceritinib or brigatinib given post-alectinib. There is another experimental drug which received breakthrough status designation called lorlatinib. They have shown response rates running about 25 to 30% after multiple ALK TKIs, which is encouraging. But there's a little bit of devil in the details. Exactly what ALK inhibitor were you on? What dose were you on? Because, as we've said, they're not all identical. So that, if it does get its breakthrough therapy label, it's after 1 or more. So that is also going to join this crowded space post-crizotinib or conceivably post-alectinib.